Good evening, everybody. My name is Syed Azhar. I am Director, ISSUP Pakistan chapter. I'm also serving at M.A. Jinnah Foundation and New Life Rehab Center, Rawalakot. Today, we as National Chapter, ISSUP Pakistan, hosting this webinar from ISSUP's platform, international membership organization, on a very important topic, comorbid psychiatric disorder in patients suffering with substance use disorders. And on behalf of ISSUP Pakistan chapter, I would like to welcome you all and thank you for your precious time to join this webinar. As many of you know that comorbid psychiatric disorder is a two-way relationship. It adds difficulty in diagnosing, managing, and rehabilitating patients. This comorbidity is also a bad prognostic factor and leads to decrease the functionality of the patients. That's why it is at most important to recognize these disorders in substance use and treat in time. For our audience, I must say that today's talk is very important for all professionals because half treated means not treated. And today we are not going to learn about two-way relationship between substance use disorder and other psychiatric disorders. In fact, we will also going to learn about patients and their families as well. And now, for more information and detail, I am going to introduce one of our very young and committed panelists, Dr. Syed Azhar with us. He is a psychiatrist by profession. He is an international certified addiction professional and national trainer UTCs by UNODC. He is a provincial secretary of Azad, Jammu and Kashmir, Pakistan Psychiatry Society. He is currently serving as head of Department of Psychiatry and Behavioural Sciences, Poonch Medical College, Combined Military Hospital, Rawalakot. His area of research is a psychosexual disorder, prevalence of SUD, pharmacological interventions in schizophrenia, comorbid psychiatric illness in patients, and alexithymia. So on behalf of ISSUP platform, I would like to welcome Dr. Syed Azhar. Thank you for your precious time and join us. Hello, sir.
Thank you very much for this invitation. And thank you for inviting me on this discussion. And this is a very important topic indeed.
Thank you, sir. And for our and before we start our presentation, I would like to share for our audience that your active participation throughout the session is very important. And for this purpose, we have muted all of you to avoid background noises, which may distract you from learning to the webinar. But during this 1 hour webinar, we have last 15 minutes for question and answer sessions. If you may have any question regarding the topic in your mind, you can send us in the question box or comment box. And after the presentation, we will request our guest speaker, Dr. Syed Azhar, to answer your questions. And now I'm going to hand over this session to Dr. Syed Azhar to please continue the session on comorbid psychiatric disorder with substance use disorders. Yes, sir, please.
Assalamu alaikum. Hello to everyone. And I'm Dr. Syed Azhar Ali. I'm head of Department of Psychiatry and Behavioral Sciences, Poonch Medical College. Today we are going to discuss a very, very important topic, that is comorbid psychiatric disorder. Today we are going to discuss a very important topic, that is comorbid psychiatric disorders and with SUD. So let us start today's discussion. This is the theme picture of today's presentation. And as you all know that comorbidity is just like adding insult to the injury. You have to treat the broken heart, and along with that, at the same time, you have to take care of the injury to that broken heart. So this means that it needs more skills, it needs more hard work, and above all, it needs a thorough professional approach towards that patient. So that's why it is important. In today's discussion, we will discuss about the positive and negative aspects of this comorbidity. We will discuss about the dual diagnosis, the substance-induced disorder, and the difference between substance-induced disorder and comorbidity. And then after that, we will discuss the specific comorbid disorders, that is the mood disorder, anxiety disorder, PTSD, the comorbid psychosis, comorbid personality disorders. And in the end of today's discussion, I will give you some very important take-home messages. So this comorbidity is related to both positivity and negativity. Dual diagnoses are insert to the injury has many associated negativities, like it adds difficulty in diagnosing as well as in managing the patient. It is a bad prognostic factor, obviously, and it increases financial burden on the patient, on the family, on the mental health system of the country. And above all, it needs more specialized care and involvement of multiple disciplines, like involvement of a psychiatrist, involvement of a neurologist, involvement of a psychologist, occupational therapist, case manager, and all the disciplines are involved in its management. But apart from these negativities, the comorbidity also has some positivity associated with it. And we can use this comorbid psychiatric symptoms, the decrease in quality of life, overall decrease in functionality, as a motivational factor to enhance motivation in that patient, to enhance motivation to quit the substance use. And as all of you have, many patients of SUD, they conceal their addiction. And sign and symptoms of a psychiatric problem, like sign and symptoms of associated anxiety, can reveal that symptoms. When detailed history at psychiatric illness, we can reveal or discover the covered SUD in that patient. So this is also one positivity associated with this comorbidity. And difficulty, when tackled positively and with good coping skills, always lead to progression. And difficulty in case management can lead to professional improvement in our professional lives. So coming to the dual diagnosis, the presence of two or more diagnosable conditions in a same patient is known as comorbidity or dual diagnosis. And they can either happen at the same time or they have close temporal relationship, one coming soon after another. So there are four categories of this dual diagnosis. That first, the psychiatric illness start, and then it the SUD start. First, there is a primary SUD with the psychiatric complication. The SUD, substance use disorder, and the psychiatric illness coming at the same time is the third category. And the fourth category is that SUD and psychiatric illness both resulting from a psychotraumatic experience or a psychotraumatic event. So these are the four categories of this comorbidity. This table that you are seeing on the screen of substance use induced disorder is taken from the textbook of addiction psychiatry international perspective, and you can see three columns in it related to benzodiazepines, related to stimulant, and related to hallucinogens. And you can see we will discuss the last row, that is the chronic effects of these benzodiazepines, stimulants, and hallucinogens. And remember that we are talking about induced disorder. When anxiolytics are used for longer period of time, they themselves cause depression and anxiety. Depressive symptoms including guilt, hopelessness, confusion, and along with some neurological symptoms like ataxia and gait problems, ophthalmoplegia, nystagmus, and memory issues. These are all related to the chronic effects of benzodiazepines or depressants. Alcohol can have the same effect. The other include the thinking problem also. So when we will see when we see the chronic effect of stimulants, we can appreciate that depression and psychotic symptoms, along with some neurological symptoms, are also related with the chronic use of amphetamines and other stimulants. And with hallucinogens, we have more neurological issues leading to cognitive impairment and long-term memory loss, anxiety, depression, and psychosis. So you can all appreciate from this table that there is a very small difference between induced disorder and the comorbid disorder. So in this slide, we will see the difference between the induced disorder and the comorbid psychiatric disorder. Duration of treatment, management plan, prognosis of a disease. These all are different in induced disorders and comorbid psychiatric disorders. So this is very important to differentiate between these two. For example, I'm giving you an example of cannabis-induced psychosis. That cannabis-induced psychosis has a good prognosis and it needs antipsychotic for 6 months to 1 year only. And when we see schizophrenia related to cannabis, in which cannabis acts as a predisposing factor, it has a comparatively bad prognosis and it needs a lifelong treatment. Some other distinguishing features are that during induced disorder, the disorders start during the substance use or soon after intoxication and withdrawal. And the symptoms in induced disorder are not adequate enough to be diagnosed as a separate psychiatric disorder. So that's why we call them as induced disorder. And in a comorbid disorder, symptoms are preceded by substance use, and symptoms persist after the cessation of substance use. And in most cases, there is a history of prior episodes that are not associated with the substance use. These differentiating points taken from International Classification of Disease, ICD-11, and that are very important to be remembered. One of the most common comorbid disorder with the SUD is major depressive illness. And as you can see from the slide, that its prevalence is very high. Normally, in normal population, up to 25% of population of the world can suffer from depressive disorder. And this is, I'm talking about the lifetime prevalence. But in SUD, it almost doubles, this figure almost doubles, and it is to 50%. So this relationship between SUD and depression has also a very important aspect, that it is a signal to diagnose or investigate for other problems like anxiety disorder, like bipolar affective disorder, like PTSD, personality disorders, and also for suicide. So whenever there is this dual diagnosis, you have to be very careful in history taking, and you have to be very careful in the use of psychometric and in the past history, like if there is any episode of mania or hypomania. And this is a great, this is a big caution that in this disorder, there is increased risk of self-harm and suicide. And as you all are aware that every co-occurring disorder has a bad prognostic effect. When we talk about the psychometric, and specifically psychometric related to this depression, this is PHQ-2, and this psychometric or screening tool has only two questions, one about mood and one about the interest for past 7 days. And if the score is 3 or above 3, then it means that the patient is suffering from depression. So this is the easiest tool to apply on a patient of SUD, and this is a very valid tool. In 2016, in British Journal of Psychiatry, which is a very sacred journal for all the psychiatrists, there is a systematic review about this PHQ-2, that it is as effective as or other tools to screen depression. And after screening, obviously you have to evaluate in detail for depression, and you have to take the detailed history for other disorders also. So this is the best screening tool and the easiest one for patients suffering from SUD. When we talk about the treatment, in mild cases, the treatment of choice will be the non-pharmacological interventions and the cognitive behavioral therapy. But in moderate to severe cases, we have to give some medications, and among them, first line are selective serotonin reuptake inhibitors like escitalopram, like sertraline, like venlafaxine, like other drugs. And the second line are SNRI and mirtazapine. And it is important to note that in opioid use disorder, first patient should be started on oral substitution therapy like methadone or buprenorphine. And if depressive symptoms persist, then antidepressant should be started. In most of the cases, OST can relieve both the craving and the symptoms related to SUD and the depression. Antidepressant use show better outcomes both in SUD and comorbid depression. This is very obvious, and this is an interesting point about alcohol, that sertraline and naltrexone, when given together in SUD with depression, they have the better outcomes. So this data that I'm telling you is derived from Maudsley prescribing guidelines and textbook of addiction treatment. Bipolar disorder is also common in substance abuse. There is 8-time increase in occurrence of this disorder along with substance use disorder, both bipolar 1 and bipolar 2. The difference between bipolar 1 and bipolar 2 is that in bipolar 1 there should be an episode of mania, and in bipolar 2 there is an episode of depression associated with the acute hypomania. There is no mania in bipolar 2 disorder. So when they occur together, it means there is a worst outcome. And we have many second-generation antipsychotics, and we can use it as a mood-stabilizing antipsychotic like risperidone or olanzapine and aripiprazole, along with lithium and valproate. They show better outcomes. And among all non-pharmacological interventions, the social rhythm maintenance therapy is the treatment of choice for this bipolar 1 and bipolar 2 disorder. Co-occurring anxiety disorder is also a common psychiatric problem that occur with SUD, and it remains unrecognized and untreated. And anxiety disorder, as you all are well aware, that it includes generalized anxiety disorder, agoraphobia, specific phobias, panic disorder, social anxiety disorders. So there is a two-way relationships, and three main etiological hypotheses were described in many books, in many textbooks, and they are that the anxious mood or anxious personality traits, they predispose a person to use illicit drugs to relieve anxiety. And the second hypothesis is benzodiazepine. People use benzodiazepine as a coping skill for performance anxiety or social phobia. And the third hypothesis about this co-occurrence is that benzodiazepine and alcohol and many depressants, specifically depressants and other drugs, they directly promote anxiety in a patient suffering from SUD. From this slide, you can all appreciate the prevalence of anxiety disorder related to different SUDs. And in cannabis, it is highest, that is 15.1%, and alcohol has 8%, cocaine 6%, and in benzodiazepine, it is 3%, opiates 3%. So as we have discussed earlier, that decreased coping skill, performance anxiety, and social anxiety, they lead to the use of SUD in some patients. Psychometrics that are valid for diagnosing anxiety or hospital and anxiety and depressive scale, that is HADS, and alcohol use disorder identification test. It is very valid to screen for depressive symptoms, anxiety symptoms, and alcohol dependence in a patient, and ASI, that you are all very well aware of. Management of these patients are very complex. And management is very complex, and this includes not only identification of the problem, but also dealing with anxious patient and the self-medication behavior. You have to deal with all these problems. And among all the disorders, you have to address different phobias, different the social anxiety, the decreased stress coping, because they can lead to the relapse if they are not addressed properly. CBT, specific to anxiety disorder, and systematic desensitization for phobias are the first line non-pharmacological interventions. And among medications, sertraline, venlafaxine, uh, these two are more recommended, and in NICE guidelines and in Maudsley prescribing guidelines, along with the pregabalin and quetiapine. Quetiapine as a monotherapy for specifically generalized anxiety disorder. And this should be noted that benzodiazepine should be avoided in these patients suffering from anxiety disorder for longer period of time. Benzodiazepine should not be given for more than 2 to 3 weeks in a patient, except in withdrawals and acute crisis. The co-occurrence of post-traumatic disorder, post-traumatic stress disorder is very high. The lifetime prevalence is up to 50%. And the hypothalamus pituitary adrenal axis stimulate anxiety response in these patients. And this also stimulate mesolimbic pathway and leading to the craving of drug and self-medication. Dangerous behavior associated with different personalities are dangerous behavior associated with SUD, can lead to fight, can lead to accident, can lead to rape, and this can cause PTSD in that patient. The psychometric that we can use in this patient is PTSD checklist. And when talking about treatment, trauma-focused cognitive behavioral therapy and EMDR are treatment of choice for these co-occurring PTSD, and SSRI are the first-line drugs, along with topiramate. This is very interesting to note that this anti-epileptic drug has shown some efficacy in this co-occurring post-traumatic stress disorder. Schizophrenia and other related psychosis like persistent delusional disorder, this is also a very common problem, and up to 47% of SUD suffer from psychosis. And remember that we are not talking about the induced psychosis. We are talking about the comorbid psychosis. SUD and this psychosis has some common etiological factors, like both are polygenic, both share some common genes like NRG1 and COMT. Both are more common in male sex and in young age, and both are related to unemployment and low educational level. So these are the common etiological factors that are associated with both psychosis and SUD. And the cannabis use can increase the risk of schizophrenia 7 times more in a population, in a patient. When we talk about psychosis and SUD, cannabis is mostly related to this psychosis, and in cannabis, the THC compound, tetrahydrocannabinol, this compound is mostly related to the development of psychosis. And THC can lead to increased striatal dopamine levels, and also this happens in acute psychosis. And THC can decrease functioning of GABA, and as in schizophrenia, and more positive symptoms than negative symptoms are in SUD related psychosis. The management of these patients, SUD with comorbid psychosis, has to be inpatient management. We cannot deal these patients as on OPD basis. The management can be sequential or parallel. Sequential means treating one disease and at a time, and then after that treating other disease. Our parallel approach means that treating both diseases at the same time, treating SUD withdrawal or intoxication and that psychosis at the same time. So in inpatient, we can use this parallel approach because engagement and motivation is a big challenge in these patients. Second generation antipsychotics and mood stabilizer are the treatment of choice for these patients. Second generation antipsychotics include aripiprazole, olanzapine, risperidone, and quetiapine. But you have to start with the lowest possible therapeutic dose and increase gradually. You have to do all the related investigations, including the blood glucose levels, the blood CP, and LFT, liver function test, renal function test before starting these antipsychotics, and specifically the heart, the cardiac related issues. To rule out cardiac related issues, you have to do ECG in these patients. And in some cases, methadone with carbamazepine, which is a mood stabilizer, can lead to withdrawal because carbamazepine can decrease the level of methadone in the blood, and it can lead to the withdrawal when we treat that case parallelly for both SUD and psychosis. Personality disorder in drug abuse. This is two sides of a same coin, and they are interconnected to such an extent that in past SUD was classified under personality pathology. And you can see from this prevalence that up to 90% of patients suffering from SUD can also have some personality disorder. So this is a huge issue. Personality disorder involve pathology in 4 components. Cognitive domain is disturbed, affective domain is disturbed, there is a disturbance in impulse control, and there is also disturbance in interpersonal functioning. You can appreciate from these 4 components that the patient suffering from SUD has also disturbance in all these 4 components. So that is why this is adding insult to the injury. When we talk about personality disorder, among all the personality disorder, these 3 are very common and mostly associated with SUD. On right of your screen, you can see the dissocial personality disorder. In the middle, with self-harm, there is borderline personality disorder, also known as emotionally unstable personality disorder, and histrionic personality disorder. These all three are very much linked with substance use disorder. Whether it is cluster A, cluster B, cluster C, all are associated with SUD, but we will talk about cluster B. That is, those personalities are dramatic, emotional, and self-centered or egocentric. And it includes antisocial or dissocial personality disorder and borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Among these cluster B, the strongest association was found to be of antisocial personality and borderline personality. And when we are talking about these personality problems, we can have more issues, and we can call it the double insult to the injury. That the 40% of personality disorder can have the gambling disorder. So in these cases, we have to treat the gambling disorder, we have to treat the personality disorder, and after that we have to treat the SUD. So it is double insult to the injury. So case management becomes more and more complex in this case. And obviously it is bad prognostic factor and high suicide rate, high forensic issues in these disorders, in this co-occurrence. These challenges are particularly related with personality issues, the issues of transparency, the issues of trust from the patient, and our involvement of therapist or psychiatrist, or resignation from psychiatrist, burnout from a psychiatrist, that I cannot deal with this patient because he or she has so many issues related to impulse control, the issues related to the follow-up compliance and to the compliance of the medication, and they all are predisposed toward depression, anxiety, and psychosis. So these are all challenges that you have to overcome in managing these cases, which is obviously very, very difficult. And that's why it needs a thorough professional approach. Cognitive behavioral therapy, dialectical behavioral therapy, group psychotherapy, and family therapy can be used as a non-pharmacological interventions. And there is a role of selective serotonin reuptake inhibitor in managing these cases. This is a very important slide and a take-home message for all of you. Whoever is listening to me, that remember that comorbidity is very common. And for assessment, we have to apply the holistic approach, that is biopsychosocial approach. We have to investigate biologically, psychologically, and socially in these patients. And it needs a team approach, involvement of all the stakeholders, involvement of all the mental health professionals to manage these cases. And it needs use of a valid psychometrics for both SUD and comorbid psychiatric problems. For treatment, you should focus on following the guidelines on the international and valid guideline for pharmacological interventions. This is very important. And never forget a risk assessment, and never forget suicide assessment in these cases. Keep updated and keep learning and keep growing. Remember that this is a long and difficult path, and both for the patient and therapist. There are slips, there are falls, there are burnouts, and on the path. But recovery and destination can be achieved with motivation, with consistency, and by applying the international guidelines. Thank you very much, Simon.
Yes. Sir, thank you very much for sharing this wonderful presentation with us. And it's really a great opportunity for all of us to learn more about substance use disorder and other psychiatric disorders together. And I must say thank you very much once again to you. And on behalf of our audience, as we have been received few questions and regarding this topic, if you could please allow us to ask some of your questions.
Yes, please ask.
So I would like to request that my first question is actually, are sleep issues linked with substance use disorder?
Yes, this is very important, and one of the common reason of relapse is sleep and psychosexual issues that is related to these disorder. Some of these drugs, like stimulants, they can directly induce sleep problems, but insomnia is also can also occur as a comorbidity in most of the disorders, and other parasomnias, they are also associated. And remember that psychosexual issues, they are all related to these substance use disorder.
Thank you, sir. And my second question is, psychosexual disorder have what kind of relation with addiction? Can you please explain this?
Yes, I have already explained it in your previous question, that these biological functions are disturbed, both sex and sleep, along with hunger. These all biological functions are disturbed in use of SUD, but they can also occur as a comorbidity in these disorders. I have already explained it.
Sir, thank you very much for explaining this once again. And now I would like to ask another question. Can SUD be associated with OCD?
Yes, in ICD-11, which is going to be valid after June or July 2021, there is a special category for diagnosing substance-induced OCD in patient. And but in the comorbidity of OCD is increased with the use of SUD, and it is very common with the use of cocaine and other related stimulants.
Thank you, sir. I would like to request you once again to answer few of our questions. And the next question is, SSRI in substance use disorder with codependence can aggravate sexual problems, then what will be the treatment plan? Can we answer here?
Yes. So Simon, this is very important question. SSRI are can cause decreased libido, and can cause orgasmic dysfunction and other sexual issues, and SUD can also lead to these sexual issues. So in a patient suffering from comorbid depressive illness, we have some other antidepressant that are not related to these sexual issues, and one of them is one of those medicine is trazodone, and the other one is mirtazapine. So we can use mirtazapine trazodone in that patient, and we can also use the non-pharmacological intervention in that patient apart from these medication.
Sir, I have another related question, that what are the risks associated with use of benzodiazepines?
Benzodiazepine, when used for longer period of time, they can themselves cause anxiety and depression. And but apart from this risk, there is a great risk that benzodiazepine can lead to the suicide and self-harm in a patient. So this is a big caution for using this benzodiazepine, because benzodiazepine, they cause a sort of bravery in the brain. So when given to a patient suffering from depression, the depressed patient can execute his or her suicidal ideas. So it is very dangerous.
Thank you, sir. I have a second last question, that should every patient with substance use disorder be screened for comorbidities?
Yes, it is must, because as you have already mentioned in your introduction that half treated means not treated. So you have to screen each and every patient of SUD for these comorbidities. Otherwise, it will be a half-managed case.
Thank you, sir. Now I'm going to ask a last but not the least question. The question is actually, after substance use treatment, some patients suffer from prolonged insomnia and decreased sexuality, leading to relapse. What should be the plan for these patients?
The plan should be regular follow-ups and the use of some sedative drugs, like the use of melatonin or the use of sedating antidepressant for longer period of time, and after rehabilitating the patient for 3 to 4 months, so the patient cannot relapse. And the proper education, proper psychoeducation about the sexuality, that this decrease in the sexuality can be a direct result of the drug withdrawal. So this can you can have your normal sexuality after some time. So this education can motivate the patient and can prevent the relapse in that patient.
Thank you very much, sir. Thank you for well explained our questions, and we had really a wonderful presentation. And now I would like to share with our audience that recording of this webinar, our presentation, will be available on ISSUP's website and ISSUP YouTube channel. You can go there and listen this website and watch this, and if you may have any question regarding this topic or presentation, you can leave your question there, and we will request once again Dr. Syed Azhar Ali Sahab to answer your question on there. And now I would like to thanks once again Dr. Azhar Ali for joining us and for your precious time. Thank you, sir.
Thank you very much, Saima. Thank you very much, Saima, for giving me this opportunity to discuss this important topic. And thank you, ISSUP Pakistan and ISSUP International.
Thank you, sir. And now, on behalf of ISSUP Pakistan chapters National Family, and on behalf of President ISSUP Pakistan, I would like to thank all ISSUP authorities and ISSUP's team for always providing us this great opportunity to share knowledge and to connect with our audience. And especially I would like to say thanks to Ma'am Jonna, Miss Ola, Miss Olivia, Mr. Michael, and Mr. Jeff, and all who always motivate us to conduct such events and contribute for this learning opportunities for our audience as well as for us. And Once again, thank you all, ISSUP Global team, and thank you, sir.
Okay.